Talking to you all about elderly patients and the general surgeon. So there are three main goals for this talk. Number one, to understand the epidemiology of elderly surgical patients, defined as over the age of 65. Number two, to understand normal physiologic changes of aging. And then number three, to understand complications that confound elderly surgical care. So there are specific complications that are described as confounding their care. So looking at the epidemiology, this is published in 2008 from the U.S. Census Bureau. So the census was in 2010. We actually had 308 million as the U.S. population in 2010. And if you look at the projections over the next 40 years, the population is expected to increase. And the various graphs here just depict whether there's an expected high migration out of the U.S. versus low migration. And then this flat curve implies that our borders are completely closed, and it would depict what the expected population would be just from childbirths in the U.S. alone. If you break it down into the seniors over the age of 65, in 2010, according to the census, there are 40 million citizens or Americans over the age of 65. And the projections over the next 20 years is that that's going to increase to 72 million. And by 2050, the projection is expected to be 88 million over age 65. So right now, the group over age 65 makes up 13% of our population. And by 2030, it'll go up to almost 1 in 5 in our population will be over the age of 65. This is just a different depiction of the age groups. It's an age-sex pyramid, again, put out by the U.S. Census Bureau. These are the 2010 numbers with the overlapping expectations for 2030, 2050. And kind of the big picture from this is you notice that the group over age 65 is going to increase significantly faster than all of the other age groups. And you'll see that there's going to be near doubling of certain age groups. So there are two reasons for this. Number one, life expectancy is increased. For those born in 1946, the average life expectancy was 66 years. For those born in 1996, the average life expectancy was 76 years at the time. And then the second reason why the fastest growing segment of the U.S. population includes individuals over age 65 is because baby boomers are a wave of population density that begin to hit retirement age this year, so 2011. So when American soldiers returned from World War II, there was a significant increase in childbirths, and 76 million people were born over a roughly 20-year period. So in 2011, now every single year, we're going to see a population increase primarily based on the baby boomer generation. So how does this affect us as healthcare providers? This is data from the National Hospital Discharge Survey. This is 2005 data. Again, it's got the population breakdown, and the age group 65 and over we've determined makes up 13% of our population today. And those folks account for 38% of hospital discharges. So this is inpatient hospital discharge data. So the elderly group makes up 38% of hospital discharges and account for 44% of days of care in the hospital. And over the last 3 or 4 decades, the percentage has increased as far as those over age 65. And primarily, it's more of there's a decrease in the groups below that, primarily because of a shift from inpatient care to outpatient care, improved anesthesia management, pain management, development of minimally invasive techniques. So there's been a shift towards outpatient care, and so more of the inpatient care is now being provided to senior patients. And then how does this impact our group as far as the general surgeons? This group looked at the, number one, again, you've got the exponential increase in the age group over 65. And what they looked at is the current per capita work per year, both by the specialty and by the age group, and compared the population forecast versus both the National Hospital Discharge Survey as well as National Ambulatory Surgery Surveys. And they found that the groups who will be the most significantly affected by the booming population of senior patients include ophthalmology, cardiothoracic surgery, urology, and general surgery. So we have essentially there are fellowships for just about everything. The one fellowship that doesn't exist and probably shouldn't exist in general surgery would be that of geriatric care. You've got family practitioners that can go into geriatric care. Internal medicine can go into geriatric care. At the CTRC, there's also a geriatric oncologist. But essentially, all general surgeons are going to be subspecialists in geriatric care by default. So it's important to understand the normal physiologic changes and also the things that confound elderly surgical care. So one of the most important concepts to understand, and a lot of this, you know, I graduated from this residency program 2 years ago, but I don't remember focusing on specifically the care of the elderly surgical patients, even though it's in our surgical textbook. You look at these 3 surgical texts, and they each have a chapter dedicated to the management of elderly patients. We talked about within the various surgical disease processes, we kind of talk about the management of the surgical patient specific to that disease process. For example, biliary disease in those in the super elderly group, those over the age of 85, or we talk about numerous rib fractures, blunt trauma in the elderly patient, but we never really talk about the things that compound surgical care and so on. So we'll touch on that today. But one of the most important things to understand is that there's a concept of the physiologic decline of the elderly. And so what it describes is, with aging, there's physiologic decline in all the organ systems. And at any given time, we all have physiologic reserves that are available to be used. So if I get sick, undergo an appendectomy, I can draw on my physiologic reserves, and ultimately there's no evidence that I had a physiologic decline. Whereas you take an elderly patient or an aging patient, along with their comorbidities, at any given time, they're already drawing on their physiologic reserves just to maintain homeostasis, even in the absence of an acute illness, operation, trauma, etc. Now you add a precipice, so you add either an elective operation, an acute illness, an acute trauma, and now they are expected to increase their reserves to achieve the same homeostatic balance. And so in a patient who already has decreased reserves, is already drawing on their reserves just to maintain their day-to-day homeostasis, you can now push them into either organ failure or even death in a precipice that in a younger patient wouldn't have that much of an impact on the patient. So we'll talk about age-related changes of the respiratory system, cardiovascular system, and then renal system. So as far as respiratory changes, there's a decreased vital capacity. The 70-year-old patient has about 50% the vital capacity of a 30-year-old patient. They have increased closing volume, decreased airway sensitivity, and decreased partial pressure of oxygen. So those changes result in less effective cough, increased atelectasis and shunting. They're predisposed to aspiration because of inability to clear the airway well. And then they're predisposed to a hypoxemia. As far as cardiovascular changes, there's a decreased maximal heart rate, decreased cardiac output, and decreased ejection fraction. And as a result of those changes, as a result of the changes that make it harder to achieve the desired cardiac output, they're increasingly reliant on end-diastolic volume to increase cardiac output. There's slowed ventricular filling, and so there's increased reliance on the atrial contribution to your cardiac output, the so-called atrial kick. So preload is extremely important in the management of the elderly patient who you need to achieve improved cardiac output. And they're also intolerant of hypovolemia, tachycardia, dysrhythmia, as well as atrial fibrillation, which takes away the atrial kick, which in sick patients can contribute up to 20% of the preload. Additional changes are decreased baroreceptor sensitivity, decreased ability for thermal regulation, diminished sensitivity to ambient temperature, less efficient mechanisms of heat conservation and production, and then the febrile response to infection may be blunted. So that will manifest as elderly patients being predisposed to hypothermia. The hypothermia now results in shivering, which increases O2 consumption and cardiopulmonary demand. And this, even in the presence of a serious infection, your patient may have a normal temperature. As far as changes in renal function and fluid-electrolyte homeostasis, the aging patient will have decreased sensitivity to fluid and electrolyte perturbations, decreased efficiency of solute, water conservation, and excretion, decreased renal mass, blood flow, and GFR, and increased renal glucose threshold. So they'll be, again, predisposed to hypovolemia, predisposed to electrolyte disorders, hyperglycemia, and hyperosmolar states. And then this is a classic chart that we all learned in second year of medical school, but we tend to forget. For whatever reason, during your training, during your practice, you'll see that patients who have a quote-unquote perceived normal creatinine of 1 will be given a contrast load, will be started on an IV NSAID, and it happens almost on a yearly basis on any of the services that we manage. But this chart here should really be a reminder that the 85-year-old with a quote-unquote normal creatinine of 1, because of the decreased muscle mass, only has a renal function that's half that of the 30-year-old with a creatinine of 1. So you can't just look at the absolute serum creatinine as a determination of your patient's renal function. And anytime you're taking care of really any patient, you need to take into account what the bigger picture is. So an 85-year-old who's small, frail, has decreased muscle mass shouldn't be treated the same way as a 30-year-old or otherwise healthy patient. So there are best practices. These are out of the Schwartz textbook. But knowing these normal physiologic changes of aging, what are some best practices we can implement to improve the outcomes in our patients or to maximize their ability to overcome the precipice? So for respiratory, early mobilization, achieving an upright rather than supine position, effective pain relief to allow mobilization and deep breathing, supplemental oxygen in the immediate postoperative period, and then minimizing the NG tube use. For 2 reasons. Number 1, it's a tether to the bed, so because they've got an NG tube, they're not being allowed to ambulate early. You're not allowing for early mobility. And then possibly it may act as a stent of the GE junction and predispose the patient to aspiration in someone who already has decreased airway clearance. As far as cardiovascular best practices, using vigorous fluid resuscitation to achieve optimal ventricular filling. And it's kind of a fine line. You don't want to put your patient in volume overload, but you also don't want to skimp on your fluid resuscitation just because your patient is quote-unquote old. So you have to achieve adequate preload because they don't have the same ability to increase heart rate, increase contractility as a younger patient. So it's a fine line between being shy with your fluid resuscitation versus overloading the patient. If you're going to need inotropic support, using non-vasoconstricting inotropes or using afterload reduction as a means to increase your cardiac output. And then using active measures to maintain normothermia, both during the operation and in the postoperative setting. And then in trauma resuscitation, it's important for all patients, but it's especially important for the elderly patient. So be aware to combat hypothermia before it onsets. As far as renal function, meticulous attention again to fluid and electrolyte management, and then really important recognizing that a normal serum creatinine in an elderly patient may represent a 50% decline in their renal function. So carefully selecting your drugs, dosing them appropriately, avoiding nephrotoxic agents. And then next we talk about specific complications that affect your surgical patients. There's really 4 of them. There are a number of them, but the 4 important ones are post-op, and not just surgical patients, but also medical patients. They're at increased risk of delirium, increased risk of pressure sores. They're at increased risk of developing or presenting with malnutrition, and then they're at increased risk of falls. And all of these risk factors increase morbidity, and in some settings increase mortality as well. So postoperative delirium, it's defined as a change in mental status with inattention and altered levels of consciousness, presents after a physiologic stress, and has a fluctuating course. And the fluctuating course is important. You may round on your patient in the morning, do your whole exam, your whole history, find that they're completely normal. You go talk to the nurse and you find that she has a completely different assessment of the patient, telling you that the patient was confused, pulling at things, had to be reoriented numerous times. So delirium is a state that has a fluctuating course, and so any one provider may not see the same patient who's delirious. The incidence, 10 to 15% of all patients undergoing surgery, 10 to 15% of all elderly patients undergoing surgery, up to 30% of cardiac surgery patients, up to 50% of emergency hip fracture repairs. And it's associated with an increased morbidity, mortality, hospital length of stay, ICU length of stay, as well as an increased incidence of post-discharge, the patient going to a care home rather than going back to their home if they were independent prior to this. This group performed a prospective study of 144 patients with planned elective surgery with a planned post-op stay in the ICU. They used a cutoff as age 50 for their study. They found that the incidence of delirium was 44%. And then, along with other studies, they noted that one of the risk factors for the development of delirium is increasing age. So you see that with increasing age, the incidence of delirium went up significantly, up to over 80% in the age group over 80. In the majority of the patients, they had no identifiable cause for the delirium. However, in 12%, they found that the patients had underlying sepsis, either had a stroke or were in alcohol withdrawal as the risk factor for developing the delirium. And in their study, they noted a significant increase in length of ICU stay, length of hospital stay, the actual cost of the hospitalization, and then post-discharge institutionalization in the group that developed delirium versus the group that didn't develop delirium. In the medicine cohort, this group at McGill University essentially followed a group of patients that developed delirium during a medical stay versus a group that didn't develop delirium in a medical stay, and found that at 1 year there was a significant increase in mortality in the group that developed delirium of 41% versus 14%. And to kind of further make the point that delirium should be treated aggressively and should warrant an aggressive workup for potential underlying sepsis or other significant complication. This is a retrospective cohort study of 14,000 patients who underwent coronary artery bypass grafting. Their incidence was 7% of delirium. They had an incidence of sepsis of 1.6%. And when they broke down the infectious complications by the delirium group versus didn't develop delirium group, they found that the delirium group had a significantly higher incidence of infection, looking at pneumonia, urinary tract infection, sternal wound infection, and sepsis. And so the conclusion here is not that delirium places you at risk for sepsis. It's that if you have a patient that you're managing and post-op they develop changes consistent with delirium, you need to take a look at the big picture and potentially do a sepsis workup. So at least look at the wound, look at your vital signs, assess your patient as a whole, and determine if there's a correctable cause that's the source of the delirium. So as far as prevention, ideally you can prevent the onset of delirium. So there are a number of strategies to prevent delirium. Number one, orienting communication, having a therapeutic activities program for elderly patients who are hospitalized, early mobilization. So if you have a patient who's on your service, admitted for a pneumonia, there's no reason for them to be at bed rest. So early ambulation for those types of patients. Early ambulation for the post-surgical patient who undergoes major surgery. You want to assess on a daily basis what immobilizing equipment does your patient have. Do they have restraints, Foleys, NG tubes, numerous IV medications that can be discontinued. You want to minimize anything that's tethering your patient to their bed. Restrict the use of PRN sleep aids, psychoactive medications. There are a number of medications associated with the onset of delirium. So these patients over the age of 65, they don't need the whole gamut of PRN meds that you see more so in private practice, but you see these preset orders which have a number of PRN meds. You have PRN Ativan, PRN Ambien, PRN Benadryl. You want to minimize that. Noise reduction strategies on the ward and in the ICU. Ideally, scheduling medications, procedures, nursing activities to allow for uninterrupted sleep. Uninterrupted sleep. And then if your patient does develop delirium, number one, do the aggressive workup to determine if there's an underlying source. And then number two, the mainstay of treatment is non-pharmacologic. So reorient the patient, the use of either sitters, or if they have good family support, you try to stagger the family visits so that there's always someone with the patient at any given time. The use of calendars, clocks, displaying days, if there's an erase board, daily changing the nurse's name, the nurse's aide's name, date, the procedures they're going to be having done. You try to reorient your patient as best you can. If they come in and they've got a history of using either glasses or hearing aids, and they went to surgery, try to get them to use it immediately post-op. Promote mobility and independence, and then quiet patient care setting with low-level lighting at night. I think this is less of a problem at university and in the Christus system, but at Wilford Hall, you had a number of immature providers who were newly enlisted. And so at night on the wards in the ICU could be pretty loud. They had the radio going in the nurses, loud conversation, which makes it harder for patients to get adequate rest. And then if you're going to use a pharmacologic agent to try to treat the delirium, neuroleptics are the preferred agents of treatment, so something like Haldol. Benzos should be avoided. Using things like Ativan or Valium really should be reserved for the treatment of delirium caused by either seizures or alcohol withdrawal. So next we'll look at pressure ulcers, another factor that can affect patient care, elderly patient care. Pressure ulcers are defined as an area of localized damage to the skin and underlying tissue caused by pressure, shear, friction, or a combination of those. Usually occurs at the bony prominences, so either the heel, sacrum, elbow, scapula, or back of the head, or there's a similar chart for patient laying supine or laying in the decubitus position. High incidence, 2.5 million patients treated in acute care facilities in the U.S. each year for pressure ulcers. The range is pretty wide depending on the institution, 0.4 to 38%. It affects 10% of all nursing home patients. It comes at a great cost, $11 billion per year for the total cost of treatment of pressure ulcers. A study out of the United Kingdom found that the treatment of pressure ulcers accounted for 4% of their total national health care expenditure. And the CMS, Center for Medicare and Medicaid Services, estimates that the cost associated with just having a secondary diagnosis of a pressure ulcer is on average $43,000. There are a number of risk factors for pressure ulcer formation. Advanced age, 70% of pressure ulcers develop in patients over the age of 70. You have to have an adequate nursing care ratio. There's got to be adequate nurses, adequate number of nurses aid to help with the mobility, turning the patients, and so on. Immobility is the biggest risk factor in the development of pressure ulcers. You take a patient who's not mobile, the normal capillary pressure is about 25 to 30, and now you have a non-mobile patient who's exerting a pressure of up to 200 millimeters mercury at the bony prominences if they're not moving at all. Pressure ulcers can develop within just 2 to 4 hours. Comorbidities, patients with underlying peripheral vascular disease, uncontrolled diabetes, maybe on steroids for chronic medical illnesses. And then nutritional deficiency is another risk factor for pressure ulcer formation. And then you have extrinsic risk factors. You have factors such as either excessive dryness or moisture, a patient who has either urinary or fecal incontinence. Excess dryness is another risk factor as well. Pressure, the duration and intensity of the pressure. Shear forces, for example, patient sitting in bed, gravity is pulling the patient downwards while the skin remains in place. And then friction, either an agitated patient who's on restraints, a mobile patient who's dragged during repositioning and they're not using the bed sheet to pull the patient up. And pressure ulcers are entirely preventable for the most part. Pressure ulcers are a preventable disease process. So much so that in 2008, the Center for Medicare and Medicaid Services placed this pressure ulcers as a quote-unquote never event. That implies that Medicare, as of 2008, would not pay hospitals for the treatment of pressure ulcers that developed during that hospitalization. So any patient who's admitted usually gets a very good head-to-toe examination. If there are pressure ulcers present on admission, it's documented. If they aren't, and pressure ulcers develop, any cost associated with that pressure ulcer will not be reimbursed to the hospital. So prevention of pressure ulcer development. There's a Braden scale for predicting pressure sore risk, essentially looking at all the risk factors we talked about. Sensory perception of the patient, excess moisture, so someone who's constantly perspiring, has fecal or urine incontinence, the presence of the patient's ability, physical ability, how mobile the patient is or how mobile we're allowing the patient to be based on either they're here for a fracture or post-op. And then you want to modify all of these factors if you can. You can't do anything about the age, but the age allows you to place that patient into a high-risk group. Inadequate nursing care, you've got to have adequate nursing ratios, CNA ratios. There's been a study done demonstrating that at least 2 hours a day of CNA care is associated with decreased incidence of pressure ulcers in 2 cohorts. Comorbidities and mobility. You want to, for the patient who's non-mobile and can't turn themselves, can't shift themselves, they need to be turned at least every 2 hours. The cutoff is at least every 2 hours to minimize the risk of pressure ulcer formation. If it's a non-mobile patient who can't adjust themselves, but they're seated in a chair, then they have to be repositioned every 15 minutes to get pressure off the bony prominences. Controlling the comorbidities if possible, so a patient who's got fecal or urine incontinence, strategies to control those. Avoiding medications that exacerbate risk, so if they're on steroids and you can get them off the steroids, that'll be important. If you're using diuretics for example, hydrochlorothiazide for blood pressure control, seeing if there's an alternative. And then correct any nutritional deficiencies, either supplemental feeds if needed or tube feeds. And then controlling the extrinsic risk factors we talked about. So a toileting schedule, frequent changing of the patient, using barrier creams after toileting and bathing, use of incontinence products to keep the skin dry, avoiding the extreme of dryness, so using moisturizing lotions, pressure relieving cushions or mattresses. So if you have a patient who you're identified as a high-risk patient, then on the day they get admitted, writing for that air mattress or special mattress for the high-risk patient. Keeping the head of the bed no greater than 30 degrees. If they're going to be supine, that decreases the risk of the shear forces. And then passive range of motion, so that when you do have your patient ambulatory or more mobile, they haven't lost all their strength to the point that now they require full assistance. And there's been a number of studies demonstrating that incidence of pressure ulcers do go down with education, prevention strategies, and then the overall cost savings associated with prevention strategies have been demonstrated versus the cost of treating pressure ulcers once they develop. And then last, we'll talk about malnutrition. With advanced age, there's a decrease in the muscle mass, increase in total body fat, loss of taste, smell, and appetite. So this graph depicts the decrease in muscle mass with age. This is CT scan images in a 21-year-old patient versus a 63-year-old patient. Again, demonstrating decreased muscle mass, increased overall fat content. So there are a number of factors that contribute to malnutrition, both on presentation and during the initial hospitalization. Socioeconomic factors, so these patients have fixed income, reduced access to food. Maybe they're relying on someone driving them to the grocery store once a week. Dependence on others for meals. Maybe they're relying on Meals on Wheels or different programs like that to get access to food. A group, the National Committee to Preserve Social Security and Medicare, they have data on median income level, the median income level. So half of seniors have an income level lower than $18,000, the other half above. 10% of all seniors have family incomes below federal poverty threshold. So these are factors that contribute to your patient presenting to you already malnutritioned. Psychological factors, maybe your patient has depression, bereavement of a lost one, dementia. Physiologic changes that contribute to malnutrition. They have impaired strength, impaired mobility and dexterity to feed themselves or to prepare a meal, poor dentition or oral health, chronic illnesses, and maybe the medications we're treating them with are causing side effects of poor appetite. And then when someone's hospitalized with an acute illness, either we're not doing a good enough job monitoring their intake or following the nutrition recommendations. Maybe we're not recognizing that they have increased requirement. Maybe they're admitted for an enterocutaneous fistula, had major surgery, and so their requirements are more than just the baseline requirements. We're starving the patients for study. On hospital day one, they're NPO for their stress test the following day. Then the following day, they're NPO because they have the acute cholestasis. They're going to go to the OR. Then the day of their operation, they're not eating as well. And then delaying instituting nutritional support may be another factor contributing to malnutrition. So this is a nutrition assessment tool and how to manage. And essentially the big picture is assess your patient. Assess your patient for malnutrition on presentation, and throughout the hospitalization, assess your patient's daily intake. Supplement the meals with snacks, small frequent meals. If you need to, obtain some kind of enteral feeding access so that you can supplement the patient either at night or 24 hours a day, and then parenteral nutrition if needed. All right, so I'll finish with 3 cases just to kind of highlight some of the points we talked about. These are all patients that I took care of at some point in the last couple years. Patient AC, an 84-year-old male, new onset of right back pain for 12 hours. Prior to this, he never had biliary colic. He does have a history of chronic low back pain, but this was a completely new pain that he hadn't experienced before. A number of comorbidities. He's had prior TIAs. He has Alzheimer's, dementia, Parkinson's disease, diabetes, a history of pressure ulcers that heals, so he's at risk of history of pressure ulcers puts the patient at risk for more pressure ulcers. But he lives at home with his wife. He performs all his activities of daily living with her help. And they have a nurse's aide that comes out about 3 times a week just to help out because they're elderly patients. On exam, he had a Murphy sign. He had rebounding guarding in the right upper quadrant. His white count was normal. He had acute renal failure on presentation with a creatinine of 1.5. His LFTs and lipase were normal. Cardiac enzymes were normal. The emergency room had obtained a CT angio to rule out an aortic dissection because of his presentation. And it was on that study that they identified the biliary disease. Because of his presentation, his diabetes, he was very tender. I took him to the OR. He had an uncomplicated, difficult laparoscopic cholecystectomy. Post-op, his creatinine rose to 1.9, probably because of the contrast load and his acute illness. And ultimately, he did well. He was discharged on day 3. As with other geriatric patients, he required institutionalization post-op. He ultimately went home, did well, but he required institutionalization on day 3 rather than going straight home. And then during the hospital stay, a lot of the stuff happens behind the scenes. Even though we talked about all these prevention strategies, all of this stuff is already done by whatever hospital you're practicing at. So in the CHRISTUS system, they get a daily fall assessment strategy. Meal intakes are documented by the nurses. Almost every single patient will get a nutrition evaluation. And then at the Westover system, every patient gets a Braden scale, at least on admission, and some patients seem to get it every single day according to the nurse's chart. So these are all the things that are going on behind the scenes to hopefully minimize the morbidity of your patient's stay while you're taking care of the patient's acute illness. So it's a big team effort that goes into making sure your patient has a decent outcome. Case 2 is just outlines how the presentation can be completely different. It's an 80-year-old woman presented she's completely demented. Okay, she requires full-time care. She lives at home with her daughter. During the day, she goes to a daytime facility for patients with dementia where they have activities for them. But she's essentially functional, okay, with someone taking care of her full-time because of her Alzheimer's dementia. She's ambulatory. She came in with abdominal pain, fevers to 105 over the last 24 hours. A review of systems demonstrated that she had shortness of breath after just going one flight of stairs. In the past, her daughter stated that she was able to do that without difficulty. And really, her only comorbidities were the dementia, hyperlipidemia, and diabetes that was well controlled. On presentation, she was old, frail, very demented. Throughout both during the inpatient setting, the outpatient setting, she had no idea who I was. Even during the same 5-minute visit, I was a new person every few minutes. But she had stable vital signs. Her fever had been treated. She had the Murphy sign. Her presentation labs were a white count of 12, normal creatinine. Her troponin was slightly elevated. And then ultrasound showed changes of acute cholecystitis. Because of her cardiac enzymes, she got a cardiac workup. And at that time, when I first saw her, I made the decision to just manage her with percutaneous cholecystostomy tube. She ultimately did well. Her cardiac diagnosis was a non-ST elevation MI. So she had acute cholecystitis, and her big presenting symptoms really was fever to 105, heart attack, and then she was septic with Enterobacter in 2 blood cultures, eventual Enterobacter in the bowel cultures. So completely different presentation. And then ultimately, she spent 8 days in the acute care setting, was discharged to a nursing home, and one of the big decisions I had to make was, what do we do about the gallbladder? It was her very first attack. When she presented, she had a heart attack. She was septic, positive blood cultures. But other than that, she's functional. Lives at home with her daughter. She eats. She's ambulatory. She goes to a nursing facility every day to hang out with other demented patients. And so ultimately, we made the decision that another attack in her would probably kill her. So we decided to perform a laparoscopic cholecystectomy electively with the plan to admit her. She did well, went home by post-op day 2. But the key teaching point here is you want to individualize your patient care. And this is for all patients, but especially important elderly patients. And then you want to take your time counseling the patient and their family members. In her case, we talked to the 2 daughters who were taking care of her full-time in a very long consent process for a quote-unquote simple surgery. I probably spent 20 to 30 minutes talking to her about the plan to operate. Brought her back one more time, had the same discussion, and then we made the decision. Because if she has a bad outcome, you want to know that you had a good relationship with the patient and they were ready for all the expected outcomes. And then the third case, it's a current patient we're taking care of. 73-year-old woman, pelvic mass suspected to be a recurrent bladder cancer. She just has a history of hypothyroidism, a history of bladder cancer. She's had a resection, neobladder construction, and subsequently that was taken down, had an ileal conduit. I was involved because the bladder mass was close to the rectum, and if the urologist got into it, they wanted our assistance to help with the resection. Very functional lady, BMI 22, albumin 4.5 pre-op. She actually went on vacation before the surgery anticipating that her post-op course would be prolonged, not knowing what her recovery might be. She had a very long surgery, 6-hour case, most of it done by urology. They did get into the rectum at the time of their resection, so we performed an LAR. A lot of blood loss, got 4 units of blood. She was stable, went to the ICU post-op. And in post-op, you see at 4 a.m., she had a Braden scale done for pressure ulcer risk. They assessed her for falls. We had her ambulatory on day 2, out of bed to the chair on day 1. And on Saturday, I'm doing rounds with the chief. And I wasn't, it's attention to details. And at that time on day 2, I really hadn't planned on starting feeds yet. But the chief talks to me and says, hey, what do you think about starting TPN? And then having now worked on this presentation, remembering the training, we decided to start her on TPN on post-op day 2. Even though hopefully the expected outcome is that we start her on the diet post-op day 4 or 5 when she has return of bowel function from her major surgery. But she's already had one setback now. She's got a urine leak. And so the plan is to provide her with nutrition to avoid the complications of potentially healing, decubitus ulcers, and so on. So to conclude, the rise of geriatric surgical care. Actually, the first reason for putting this talk together was a marketing tactic. For me, it was I was going to talk to a geriatric group and try to get some business from them. So that was my number one role of putting this, a shorter version of this talk about a year ago. But really, it's going to affect all of us, and we are all geriatric surgical specialists. There's no need for 1 year of training for anyone to do this. We just need to all be able to take care of geriatric patients. Understand the normal physiologic changes of aging, and then understand the complications that confound elderly patient care, with a lot of it being done at the hospital administrating setting as part of a big team. You've got your nurses, your dietitian, your PT/OT, all contributing to the patient care. So with that, I'll take any questions. Yes.
You alluded to this in your case presentation. Can you talk for the residents and medical students about some consent issues, powers of attorney, who can sign what? So that's a big part of this process.
For elderly patients, especially the patient who's demented and has already had the family involved in their care, they haven't been independent all this time, they usually have a power of attorney, which a family member assumes the I guess the legal rights to make the medical decisions and the everyday decision making for that patient, as long as the patient is incapable of doing so. So usually, if they have a power of attorney, there's one person that you can go to obtain informed consent. You still want to involve the entire family, because invariably you're going to have someone flying from California, from New York, whatever, and then get all, quote unquote, all in your face because they haven't been involved. All of a sudden they're involved, and so it's important to talk to the whole family. Does that address your question?
Just, be real careful. What if they didn't have a power of attorney? Where's the resource?
If they don't have a power of attorney, then you go to the number one, the husband or wife, if they're not demented, and then number two, the family members, daughters, sons, etc. So you don't have to have a power of attorney to have to obtain informed consent. but you do have to go down kind of the number one, the significant other, number two, the son, daughter, etc.
A lot of the problems, I think, arise from multiple siblings who have different plans from what we've seen in the past, as far as what they want for their parents. Other questions for Dr. Nguyen? Jack.
You said something that goes against one of the giant forces in medicine today, which is individualized care. Everybody's trying to get everything on pathways, so your pathways can be monitored so we can determine if you're meeting the standard. And you're talking about individualizing care. And what I wonder is, and I went through this recently with a 65-year-old who wanted a colostomy takedown. And I talked to her about maybe just living her remaining years with a colostomy, and she said, all my parents and all my grandparents all reached 102. I'm not going 35 years with this bag. Please take it down. And this was a lady who had failed colostomy takedown in an 8-hour procedure by another surgeon before she was referred to me. So living with her colostomy was a pretty good option, in my opinion, but she talked me into it. And I think, in my mind, it could be the decision tree or an algorithm, but the hard part is the patient's current function and their life expectancy. And so you've got some 60-year-olds have a life expectancy of less than 5 years, and some 90-year-olds are mowing their own lawns and driving themselves around and reasonably functional people. And so it's not just age that makes the decision. And the hard part is getting some of those guesstimates about life expectancy and how functional are they. But I'd appreciate your thoughts on that, because individualizing care sounds good, but if you're going to start monitoring your outcomes, you got to have some way to know what led to your decision making. Right,
and I mean, there's no pathways for the case you talked about. There's really no pathways for even biliary disease for the 81-year-old woman with acute cholecystitis and the decision to take her gallbladder or not. What her life expectancy is. If you look at pathways, though, and I haven't seen that many pathways related to this, but there's always kind of an out for pathways. Like if you look at the pathway for prostate cancer screening nowadays, really the recommendations say starting the age of 50, you should consider talking to your patient about the potential benefits of a digital rectal exam or a PSA screen. So pathways can be difficult because you've got the pathway for the quote-unquote usual patient, but as soon as your patient is the unusual patient, there's no pathway down there that says this is what you do. So I think even pathways, you still have to individualize patient care, because for your patient, there's no pathway, but there's probably 50% of the surgeons out there would say, I would just send her out and say, I'm not going to do your surgery. And then the other half would do it. So I'm not sure how you address this problem, unless you can come up with a computer model to input all these factors, including how ambulatory your patient is, nutrition status, life expectancy, comorbidities, cultural beliefs, all that stuff into a computer model.
Actually, what Dr. Dent is talking about, what we always see, we're talking about chronologic age, and you have to be careful that you're not prejudiced with your medical and surgical therapy just based on somebody's chronologic age. And what you're really talking about is physiologic age. And unfortunately, just like Cornet's talk last week, we need a probe sitting in the mitochondria to tell about what the oxygen demand is. Unfortunately, we can't assess that physiologic. I think a lot of it comes just from clinical acuity with time. I don't think adding up all these different things sure, most of our patients come to us with lung, heart, and kidney problems. Those are the three major organs that are going to determine whether you're going to make it or not. And I think the SCIP data showed that whether a patient makes it or not depends upon the comorbidities that they bring to the table at the time of an elective or an emergency operation. Dr. Jitoy.
Yes, one of the things that I find interesting is, with your literature review, there are no randomized trials that you address with regards to the elderly. And it's interesting, a couple of years ago, I think it was Kathy Albane, one of the people from SWOG, looked at cancer trials, and they almost always had exclusion criteria, and the elderly were excluded from participating in clinical trials. And they usually had a cutoff of 65 or 70. because the feeling was these patients were too sick to participate in clinical trials. And now what we're seeing is more and more of our patients are elderly. And we don't have any clinical trial data. We don't have any randomized clinical trials that tell us how to take care of these patients. So I guess my question is, should there be a change in mindset? I mean, we're excluding patients from clinical trials that are elderly, and yet this is the most rapidly growing segment of our population. And as a result of this, as a result of these exclusion criteria, we really don't know how to take care of these patients.
I think it's important to do it, and I guess the question is, it would be folks like us who understand that now this is going to make up the majority of our inpatient stays. It's going to make up a big part of the patients we care for, and I think the way to do it is with randomized clinical trials. But I guess the question is, are they being excluded because they're concerned that they're going to affect the outcomes of the study and therefore make it a non-valid study?
Well, I think the concern is they're too sick to participate in trials. I mean, they've got too many comorbidities. Well, that's true, but at the same time, we still need to know how to take care of these patients, and it's a dilemma, I think, that needs to be addressed at some point with regards to exclusion criteria in clinical trials.
Is it your overall opinion, though, that elderly patients do not tolerate chemotherapy as well? Not necessarily just because of the comorbidities?
Well,
it has to do with their reserve, I think.
Well, I think it's what you just pointed out. There's a physiological issue. So physiologically, some are very able to tolerate it. But the unfortunate thing is we just don't have data on elderly. I mean, we just don't. When an elderly comes into us and says, well, what effect does this drug have on me? We don't know.
Used to bring up about when we talked about operating on somebody 90, and his answer to everybody's concern about operating on somebody 90 is that that individual has a better chance of making it to 91 than anybody else in the room. Dr. Cruz.
That was really truly superb, albeit a little, not just a little bit sobering, but it is downright sobering, because in many instances it's not attainable. I think if you're going to operate on old folks, I think that with a low qualification, that you need to make sure that your pre-op, operative, and post-operative care is going to be perfect. Because if you miss a step and something starts going down, you've started the cascade, and it takes superhuman or even impossible effort to reverse it. But the truth of the matter is you really have to watch everything like a hawk so that things go well and the cascade does not start. And the other thing is that amongst old folks, I remember when we were in training, one of the standard orders was about restraint. So they were all placed in the bed after surgery. And looking at it kind of reminds me of the gurney that you use in the execution chamber. I know that's, it may be funny, but you just search your memory book a little bit, and you'll find out that that's part of the bed preparation. And I think that the things that you put in here and your plea for individualized care and superhuman effort are going to be needed in each individual patient. And I cannot just,
Well, what you're saying is paying attention to detail.
Right.
And they cannot tolerate one major complication.
Absolutely not.
You were lucky with your patient who got the contrast and the creatinine bumped up to 1.9, because sometimes all we needed was one other little insult, a little non-steroidals on top of it.
Use care like chemotherapy or combination multimodal treatment just because of the patient's chronological age. Because many of them are eliminated for potentially beneficial treatment.
Dr. Dan?
Yeah, I was just going to say, getting to Dr. Tully's point, there's some data out there, but they don't look at the whole end. So, for example, there's a paper out of the Moffitt Cancer Center looking at giant cancer operations in the elderly, and they looked at esophagectomies, Whipples, and liver resections in patients over 70, and they had great outcomes. But what they couldn't say was how many people they turned away. And they guesstimated they were turning away about 80% of those over 70 who had a disease process that would make them a candidate for that operation, but they turned them away because they couldn't take the operation. But they didn't know the actual number they turned away or any way to actually select the patients. And so that's kind of what Dr. Nguyen, I think, was getting at, is it's patient selection, but it would be nice in the next 5, 10, 20 years, this field of geriatric surgery, we were able to get some good guidance through some good prospective randomized trials on how to select these patients for chemotherapy, cholecystectomies, ostomy takedowns, Whipples, whatever we're going to do. Trauma, we don't get to select; they just show up. But for elective surgery, we get to select them, and guiding us in patient selection, I think, is going to be absolutely crucial.
I think one of the issues has been, like, for example, industry doesn't like to include elderly in their cancer trials because the results are oftentimes dampened. They like spectacular results. And if you include elderly, you dampen the results, and the likelihood of getting approval and so forth might become more problematic. So there's always been this bias against recruiting elderly into clinical trials, and I think that needs to change because that's the fastest growing segment of our population, and we need to know how to treat them.
At the beginning, I neglected to introduce Dr. Nguyen. Dr. Nguyen is a graduate from UT Austin, is a graduate of this medical school, and is a graduate of this general surgery residency, and he was actively recruited to join the general surgery faculty. And based on this talk, you can understand why we were quite happy to go ahead and recruit Patrick. He's also received outstanding teacher awards from the students, if I remember correctly. Is that right, Dr. Estrell? And another demonstration of why. Patrick, thank you very much.
Thank you.